All right, let's talk about a symptom you're going to see all the time on the wards, but one that can be surprisingly tricky: oropharyngeal dysphagia. Trouble swallowing. In this explainer, we're going to walk through the entire clinical encounter step by step, from the patient's first words all the way to your final management plan. This is basically the practical guide you'll wish you had.
So, here's our game plan. We're going to follow the clinical journey exactly as you would. We'll start with how the patient presents, then move to your initial workup at the bedside, and then figure out how to narrow the diagnosis. After that, we'll get into the diagnostic tools you can order and wrap it all up with the different pathways to management. Let's dive in.
First up, the presentation. Before you can diagnose anything, you got to know what you're actually looking for, right? This is all about understanding the official definition and, more importantly, learning how to translate what a patient is telling you into a real clinical suspicion.
So what are we really talking about here? At its absolute core, oropharyngeal dysphagia is that feeling a patient gets, that sensation that it's just hard to get food from the mouth to the back of the throat to actually start a swallow. The key words there are transfer and initiate. The problem is happening right at the very beginning of the whole process.
And this is what that fancy definition actually sounds like in the clinic. Your patient's going to point right to their neck, saying it feels like something is stuck. They'll tell you about coughing or choking when they eat because, things just aren't going down the right pipe. You might even hear about nasopharyngeal regurgitation. Yep, that's food coming up the nose. And you have to keep your ears open for those big red flags, like a past history of aspiration pneumonia or weight loss they can't explain. That tells you this has been going on for a while.
Okay, so let's move on to the next part of the encounter, the initial workup. This is where your fundamental skills, just taking a good history and doing a focused physical exam, are going to give you the most valuable clues about what's going on.
Your history taking here is basically detective work. Every question is a potential clue. You hear about smoking and ear pain, your brain should immediately jump to a possible structural problem, maybe even a malignancy. They mention their voice has changed or sounds hoarse. Now you're thinking about a neuromuscular cause. And hey, if they tell you they're bringing up undigested food hours after they ate, that's practically textbook for a Zenker's diverticulum. Oh, and don't forget this little gem. Ask if they get tired while they're eating. That is a fantastic clue for myasthenia gravis.
Now for your physical exam, you have to be laser focused. A quick look in the mouth, a feel of the neck, that's standard, but the real gold is in the neuro exam. You've got to quickly run through those key cranial nerves for swallowing, that's 5, 7, 9, 10, 11, and 12. Is their voice hoarse? Could be a vocal cord issue. Are their eyelids drooping a bit? You should be thinking about a myopathy. And you know what? Even just noticing a subtle shuffle when they walk could be your very first clue to something systemic, like Parkinson's.
Okay, so you've gathered your initial data. Now comes a really critical step, narrowing the diagnosis. You have to be able to confidently tell the difference between oropharyngeal dysphagia and a couple of its most common mimics. This is probably the single most important distinction you're going to make at the bedside. Oropharyngeal dysphagia is trouble starting the swallow, and it's felt in the neck. Esophageal dysphagia happens seconds after the swallow starts, and it feels like food getting stuck down in the chest. The question to ask your patient is super simple. Does the trouble happen the second you try to swallow or a few seconds later? I'm telling you, the timing is everything.
And here's the other big point of confusion: globus sensation. That feeling of a lump in your throat? The key difference here is its relationship to eating. A patient with oropharyngeal dysphagia has a real problem with the act of swallowing. A patient with globus feels that lump between meals, when they're not swallowing anything. It's a sensation, not a mechanical failure.
All right, you've narrowed it down, and you've got a really strong clinical suspicion. Let's move on to investigating the etiology. Now we're talking about bringing in the big guns, deploying the right diagnostic tools to confirm what's happening, and most importantly, why.
So how do you decide what to order? Well, the diagnostic pathway is actually pretty logical. If your history and exam are screaming neuromuscular disease, you'll probably start with a video fluoroscopy, or VFS. That's a live video X-ray of the swallow. If the picture is a little less clear, you might start with a FEES, which is an evaluation with a scope. And hey, if that FEES exam doesn't give you a clear answer, you can always move on to the VFS.
So let's compare these tools real quick. Think of the video fluoroscopy, the VFS, as a movie of the swallow. It's really the best way to see the mechanics, how all the parts are moving together. The FEES, on the other hand, is like getting a direct close-up look at the anatomy with a scope. And you can even do it right at the bedside. Then you have manometry, which is different. It's all about measuring pressures. It's useful, but it's not usually the test that changes your immediate plan. Each tool is designed to answer a different question.
So, you've got a diagnosis. Now for the most important part, what do you do about it? Let's talk about the pathways to management, which can range from simple rehab exercises all the way to surgical interventions. Regardless of what's causing the problem, the goals are always simple and totally patient-centered. Goal number 1, improve food transfer. And goal number 2, prevent aspiration. Every single therapy we choose is aimed at one or both of these things. That's it.
This is where your collaboration with speech and language pathology is absolutely critical. These aren't just random movements. They're very specific maneuvers designed to compensate for specific problems. For example, turning the head toward the weaker side physically closes off that path, which forces food down the stronger, more functional side. Or the Mendelssohn's maneuver, where a patient actually learns to prolong how long their larynx stays elevated to help open up that upper esophageal sphincter. It's basically targeted physical therapy for swallowing.
The overall approach to management really follows this intervention ladder. You always start with the least invasive options, rehab and dietary changes, like thickening liquids. If the dysfunction is really severe and the aspiration risk is high, you have to consider enteral nutrition, like a G-tube. And for very specific mechanical problems like cricopharyngeal dysfunction, you can escalate to procedures like a myotomy, balloon dilatation, or, as a last resort, even botulinum toxin injections.
Now here's a huge clinical pearl for you, especially when you're thinking about that surgical myotomy. The presence of dysarthria, slurred speech, actually predicts a poor response. So why is that? Well, it suggests there's a more global neurologic problem going on, and just cutting one little muscle at the top of the esophagus is probably not going to fix the whole picture. It's a really key factor in patient selection.
So for the right patient, how well does this surgery actually work? Well, the data shows a response rate of around 60% in patients whose dysphagia is caused by a neurologic issue. Now that's a pretty respectable number, but it also really highlights why that patient selection is so crucial and why it's so important to set realistic expectations with your patients.
All right, we've walked through the entire clinical encounter. So let's boil it all down to the key takeaways, the stuff you can actually bring with you to your next shift.
Here it is. This is your mental checklist for the next time you see a patient who's having trouble swallowing. First, start with that super detailed history. Remember, timing is everything. Immediately, in your head, differentiate it from esophageal dysphagia and globus. Your exam has to be targeted, focusing on those cranial nerves. Then choose your diagnostic test based on what you suspect is going on. And finally, always remember that management is a spectrum. Follow these steps and you will have a clear, effective plan every time.
And that leaves us with a final question to think about for the future. As our diagnostic tech gets more and more powerful, will tools like high-resolution manometry ever replace the value of just a careful history and a thoughtful physical exam? It's something to think about as you move forward in your training. Thanks so much for joining me.